welcome, Dr. Gaurav. He also has to go to OPL, I think.
Yeah.
That is why his attire is like that.
Yeah.
So anyway, he'll talk to us on subluxated cataract.
Yeah, yeah. Thanks, and so Partha pushed me out of the OPL saying, you go and give your talk there. I said, okay. So I was visiting Calcutta for a live surgery session just about few months back, and I was given this patient to operate, and this is a real live surgery feed only. So they said that you can do one challenging case and one regular case. I said, okay. And this turned out to be the challenging one. So patient had a Morgagnian cataract, and this is how it looked on the slit lamp. It had been seen, and the capsule didn't look very healthy, and you can see the nucleus, kind of resting there. And of course, all the workup was done, everything looked good, and I was asked to come and see the patient on the slit lamp before the surgery. So I went and checked out the patient. I felt there was phacodonesis, but it was decided that we can go ahead in spite of, it was either just the nucleus which was moving, but I felt that there was a phacodonesis also. So we went ahead and started the surgery. A toric IL was planned for this patient, went with my incisions, and wanted to stain it. So I put the stain. Now just keep watching what happens. I stain, but in an area nothing happens. It doesn't stain. So then we stain again. I go back, try to stain there, and this time it stains. But look at how it stains. The stain can't wash out. So I'm sorry, it's a little edited here to make it 4 minutes as Partha wanted me. But if you'll notice here now, the stain I'm washing, but that stain is not going away. So I realized that this is something else. It's actually vitreous which got stained, and I'm now using the cutter, and I've removed the vitreous from there. It was basically, you'll see again that I'm going there now with the cutter in my left hand, and I do a vitrectomy. That was stained by trypan blue, so just like tricot. So now we know that there is a problem. The vitreous was already in the anterior chamber. I have to now get my rhexis in place, so that you can see that there is good amount of phacodonesis. And now at this point, all the milky stuff comes out. I use my microrhexis forceps to grip it and try to complete the capsulotomy, but these capsules are not very nice, and there's a fibrotic band there which I have to cut. It won't kind of tear. So as I now cut it with the side port scissors, now I'm able to proceed. You can see all the shiny crystals peeking out from that Morgagnian cataract, and then it's difficult to visualize the capsule because of all the milky stuff, and you can see how loose the capsular bag is, and of course there is that big nucleus sitting inside, which we saw on the slit lamp photograph. So not only is the lens subluxated, the capsule is very unhealthy, there is also vitreous in the chamber, and now I have to start with the second part. And luckily at this time the other OT is already set up for a VR surgery, so I have that comfort that there is a backup VR surgeon sitting in the other room. So I'm fearlessly going to proceed, and as you can see that it was a Morgagnian cataract, a very hard nucleus there trying to embed and chop. And of course this lens is quite mobile as well, the capsular bag, able to kind of make some progress. And all this is happening in real time, so it's a live surgery, and I'm getting all kinds of commentary from behind that why don't you do this and why don't you do that. You can see on the left here in that small window is all the people standing around and trying to give me a lot of guidance. And when you do it in your own OT setup, it's a different matter, but when you're operating in a live surgery environment, it becomes all the more challenging. So Morgagnian cataracts can be better dealt with, pushing them against the equator of the bag, except that in this case the bag itself is suspect. So somehow we have to ensure that our chopping happens without putting any stresses on the bag. And so behind that the bag keeps moving all the time, and I'm worried that at any point it will give up. Actually the capsule was very, very friable, and it was ready to collapse at any time and come into the phaco-port. So managed to get that nucleus out. And now checking for the integrity of the capsular bag and looking if there is any. So we decided to go with only a CTR and not fixate the bag completely. and I'm passing a suture through the eyelet of the CTR because I'm not 100% sure is not going to dislocate into the vitreous cavity, because the bag looked very, very flimsy and I was not sure it's not broken somewhere in the equatorial area. So I insert this because just in case the CTR starts dislocating, I will only have to pull the suture and ensure that it comes out. So now that I'm confident that the CTR is sitting nicely, the suture is no longer required, I'll just pull on it and tug on it, and the free end will come out, and now we are kind of ready to implant the lens. And thankfully we could complete that surgery, and while there's no horror in this, the only challenge was that doing this in a live surgery environment and in a new place with a new microscope and a machine which you are not kind of very used to, made it even more challenging than usual. But if there are any comments, I would be happy to.
Is there any particular reason you did not apply iris hooks or capsular hooks or a CTR in the beginning?
So, if I had felt the need for the capsular hooks, obviously I would have done that. But because I could proceed, it was a Morgagnian cataract. All I had to do was improve my settings so that the nucleus, because I was not using the bag for anything. I was basically getting an embed onto the nucleus and then making sure it's kind of nicely embedded. My phaco tip is embedded nicely and I can chop. Of course, if there were like a big nucleus which was needed manipulations and like posterior plate cracking and all that, I would have had to put in a capsular hook, because then there would be a backward force on the capsular bag. Here it was like a free floating nucleus which was just inside the bag. I just wanted it to remain there and crack it with just chopping maneuvers where I was not really going to put any forces on the bag as such. So there was no need, and of course I was sitting ready with the CTR. At any point if I felt that there was a need to put in the CTR. Usually if the bag starts collapsing, and especially like towards the last one or two fragments of the nucleus when they are left, you see that the support of the nucleus is lost. The capsular bag, if it's really, really bad, it starts collapsing onto the phaco-port. It starts coming into the phaco-port. That's when I would normally immediately put in a CTR. And yes, of course, if there's the lens is dipping down at any one of the places, then I'll put in a capsular hook. But if it's not kind of tilting down at any point, I may not put a capsular hook. I might just put a CTR and get away with it. And then later on decide if I want to anchor it with a capsular tension segment or something. So that's how I usually proceed. But yes, I mean, it's your comfort how you would like to do it. So.
And empty bags, when you're doing a phaco in that, how would you think the use of dispersive viscoelastic into the bag would help you, and also changing your flow settings during phaco?
So Morgagnian cataracts do carry that challenge because there is no support of the cortex, the epinucleus, all that is missing. And especially if the bag is not healthy, like in this patient, it tends to kind of keep jumping up with even those small changes in fluidics. That post-occlusion surge kind of thing, it tends to come straight into your phaco-port. So putting in viscoat is always great. So when I'm dealing with such bags where there is a suspicion of empty bags, and also if there's some kind of zonular dehiscence or laxity, I love to fill it up with viscoat inside and then proceed with that cover of viscoat which stays there for like maybe 2-3 minutes till you're comfortable. You're absolutely right about that. So also, if you have a Morgagnian kind of a thing, it's good to kind of push it towards the equator of the bag, because that kind of tamponades, and then you can embed more easily. Otherwise, if you're trying to embed it onto a free floating nucleus in the middle, sometimes you won't embed so much. But if you kind of move it away towards the opposite to your phaco incision and take the support of the bag and embed, then it works better. Just like we do for the second half of any nucleus is what I would do.
Have you done implantation of an IOL into the bag first and then do the phaco?
Yeah. So few Morgagnian cataracts, what I would do is to have that scaffold. It works very well actually. Here, because I was not confident that in the end whether this bag is going to retain even the CTR that I put inside. It doesn't look so difficult here. The bag was looking so unhealthy all the time. I was not sure that there is no kind of puncture in the bag somewhere in the periphery, and whether the CTR will actually remain in the bag or just give way. So right till the end we were not confident this bag is going to be intact. But you're absolutely right that putting an IOL scaffold inside and then emulsifying on top of that makes life so easy. Absolutely.
This vitreous in the AC, many times we do not dilate these kind of hypermature cataracts on the slit lamp. But if we dilate well on the slit lamp, if it is the AC is not very, 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 especially in Morgagni, you don't get very shallow antechambers. then you will see
You
this
should
kind
be
of
able to see
knuckles
it.
in the
Absolutely.
in the AC
In
before
fact,
itself.
you're right. The thing was, when we reached the hospital, this patient was not dilated. I saw only through a small 2-3 mm pupil. Obviously, I didn't see the vitreous. Even the phacodonesis was not as evident. So, in fact, I pointed out that, this patient seems to have some phacodonesis, but I was reassured with all the notes and everything, that it's been seen properly. And then, of course, patient was dilated, and I operated about 2 hours after that when the patient was already kind of in the OT. But the first thing I saw was the vitreous getting stained with trypan blue, and that's when I realized that it's vitreous. So, but it was easy to manage the vitreous because once you've done it, and once you put viscoat into the chamber, and especially in that area, the tamponade will keep the vitreous behind, and then when you put the CTR, it ensures that it kind of expands the bag and the vitreous will not creep up. But during surgery, you have to be always very alert. If the vitreous again starts creeping out, you have to go and clear it up. Otherwise, you'll keep increasing the dehiscence, and you'll probably catch the vitreous in the phacoprobe. You'll increase the amount of dehiscence, and the vitreous will keep coming to complicate. And so you have to be always alert. If you suspect vitreous, put in triamcinolone, check if there is any vitreous, clear it up, and then proceed. So that's how I would do it.
This role of this limited vitrectomy and tamponading it with viscoat or a dispersive viscoelastic in that area and replenishing it on and off, and also to reduce your flow rate, and also to keep your probe away from that area while you are chopping or aspirating, are, I feel,
Very
added, they give added advantage to
Absolutely.
prevent this vitreous from coming out. Limited means I meant take out only what is there in the anterior
I
chamber. So
completely
keep
agree.
on aspirating, you keep on going there
It
and
keeps
aspirating,
coming.
it will keep
You
coming.
you kind of go in that area and it'll keep coming, and then you'll have the vitreous in the posterior compartment will become less. Your lens support will go away. So it becomes very bad because I always, as you said, I would only remove what is visible to you. I will not go chasing it for sure. And again here, because there was no role of a posterior approach for vitrectomy, because all we had to deal with was what was blocking our access to the lens. So, but if there was a lot of upthrust and other things, small eye, very shallow chambers, you can go do a pars plana, a little bit of vitrectomy, but here it was not required. So you don't have to do that in every patient. Some people advocate that, all these patients don't do anterior vitrectomy ever and always go from the posterior approach. I feel you have to decide on a case-to-case basis where you can get away with just a decent anterior vitrectomy and where you want to go posterior approach where you have vitreous coming and causing problems to you with upthrust.
And lastly, cutting the capsule, the fibrotic capsule. Many of us feel that it will weaken the rexes, and usually, as you have shown, it doesn't give way just like that. So you can boldly cut on the this one when you are running into that area during your rexes. You don't have to, but then beyond it or away from the tear or the fibrosis, if there is a nick, then that can be a weak area. So it better flush cut along the tear and then continue on. And during CTR implantation also did not give way.
Did not give way. Yeah, so because it's fibrosed capsule, and you're right, only thing is that you have to remember that that area is going to be a little weak, and if you are doing any maneuvers like during the IOL or cracking the nucleus, you have to be careful that that particular area is not kind of stretched. Otherwise, that's a weak point of the rexus, and you should always be careful. So.
Any more questions to Dr. Gaurav? He's going to leave. He's going to go to.
Good morning, sir. I am a second-year resident, sir. Sir, I have a question, sir. What tips would you like to give us for the residency? Had it been a case of pseudo-exfoliation syndrome with a Morgagnon cataract, sir?
A pseudo-exfoliation with a Morgagnon, I would think that only if you're proficient you should be doing such cases. Once you've done a few hundred cases, then you should tackle a case like this maybe, or with pseudo-exfoliation, because pseudo-exfoliation itself means that there could be zonular weakness, and then the rexus will not tear as easily as it would, right? So if you have a pseudo-exfoliation itself, I would definitely want you to have good viscoelastic there, and ensure that I would put a rexus mark on the cornea to make sure that I know what size rexus I'm going to make, and then use a micro-rexus forceps from the side port, because when you try to do it with a bent cystotome, you will not get that good control. So you could start off with a cystotome and then quickly switch hands and go to a micro-rexus forceps, and keep holding it very close to where you are tearing it, and keep replenishing viscoelastic till you have the right size. Sometimes if you are getting a smaller rexus, you can take one round and then go for a second round as well, because that will not tear very easily. So you can always enlarge the rexus, but Also at the end of surgery in pseudo exfoliation eyes, it's a good idea not to leave behind a very small rhexis because they tend to go into a capsular
Yes,
bag
sir,
contraction
capsular
syndrome, and you may have capsular phimosis. So even if you have got away with surgery with a relatively small 4 rhexis, at the end of surgery you can give a small nick and enlarge the rhexis to just run inside the edge of the optic and not leave it with a bag which can go into phimosis very easily.
Sir, in pseudo exfoliation, till the last moment of placing the lens, sir, we have that fear of dropping the lens as a resident, sir, like
Absolutely,
in, as a
yes,
perspective
yes,
in our perspective we are seeing.
yes.
So will it be fine if we do a optic capture in that case, sir?
So, for what? Optic capture, where do you want to do it? Like
In
you
the
want to put the
in
lens in the
last moment,
sulcus
sir.
and
Yes,
then
sir.
put it in the bag?
Yes, sir. Yes,
The
sir.
optic?
Yes, sir.
You could do it. I mean, if you have so much of zonal laxity that you fear that the capsular bag complex, IL complex bag will dislocate and you want to put a 3-piece into the sulcus, don't do an optic capture with a single piece for sure. It won't stay there. But if you do it with a 3-piece and capture, there's nothing wrong with it. A CTR really helps in a pseudo exfoliation eyes because that keeps the bag more kind of healthy, and the peripheral attachments also, it will keep them intact. But yes, also have a backup surgeon who is there to help you just in case you need it. Never hesitate to ask for help.
Yes.
Okay?
Thank you, sir.
Great.
Yeah, as a resident, if you do pseudo exfoliation, after you become a consultant after 10-15 years, if you are there itself, they will come to you because it will progress. Most of them will progress, and the pseudo exfoliation contraction will happen, the rupture will happen, and it is going to drop.
Yes.
Many of them. So, as in this case, and if you say it's hypermature pseudo exfoliation, better fix the bag before placing the IOL or after placing the IOL. So, without fixing the bag, if you leave it, you'll be happy for a while. After that, the patient will come back to you or somebody else, and it is going to dislocate. So, hypermature means it has become a little advanced, and it is advanced with phacodonosis means you have to fix the bag also.
Yes, sir, yes, sir.
And the capturing part is a great idea. But if I put it in the bag, as he said, I would relax the rhexis, even if it is quite large. I would relax the rhexis, but then larger 5.5 and capturing it in and fixing the bag would be the ideal thing to do if it is pseudo exfoliation with the hypermature cataract.
Yes, sir. Sir, one more question, sir. In pseudo exfoliation with hypermature, will it be better to turn into a manual SICS?
That is what the last question I wanted to ask Gaurav.
Yeah.
In such a case,
Yes,
if
sir.
you are good enough with the SICS and if you are confident
sir.
that you can do an SICS well, it will be, and if you have done enough SICS and
Yes,
you are
sir.
confident, then SICS will be slightly more easy than
Better
experts
and
doing phaco in this kind of. Don't get carried away by experts doing phaco in these kind of cases. And if you feel anything in doubt, and if you are good enough in SICS, I would do SICS and open up the bag and take out the nucleus and cleanly create a rhexis and place the IOL and come off.
I completely agree with that. Whatever you are comfortable with, because SICS will have less scope for disasters to happen, for sure, in such situations. And doing an SICS would be absolutely acceptable, especially if you are more comfortable with that. PECO is more challenging in such cases.
Yes.
Right?
Okay. Thank you so much.
Thanks,
As a
thanks for
senior
accommodating
resident,
me.
I will suggest you to
Thank you,
first
Gaurav.
go
Gaurav
for
has to
the
leave. Thank you. Bye bye.
SICS.
Yeah, sir, we do phaco in Morgagnon cataract in pseudo exfoliation.
In
We
these
prefer
cases,
SICS.
I will
in the-
suggest if you go for the SICS, that will
Yes,
give
sir.
you a better result.
Yes, sir.
Ultimately, patient's vision is the most
Yes.
important thing.
Then going up for challenges.
Exactly.
Yes, okay. Thank you, sir.